First and foremost step while evaluating a chest X-ray, and for that matter any investigation, would be to verify that it belongs to the right person by checking the identification. Then coming to a chest X-ray, we would look at the position marker. When mounting it on a viewer, you have to see to that it is mounted properly. Very often we miss situs inversus and dextrocardia just because we don't check at this marker. PA view is taken with the sensor in case of digital X-rays or X-ray film in case of conventional X-rays just in front of the chest, and the X-ray tube is posteriorly placed, usually at a distance of about 6 feet, so that the rays are almost parallel when they reach the chest. Otherwise, cardiac shadow can be magnified. Cardiac shadow can be magnified in an AP view. That's why we specify PA view in erect posture. You can identify the erect posture by looking at the stomach air bubble, which will show an air bubble below the diaphragm, left hemi-diaphragm normally. And when you go by a sequence, you go look at the bony cage and soft tissues first before looking at what you're seeing obviously. In a good position, you will see that the spine is midway between the ends of the clavicles, and you will see the tracheal air shadow in the center with a slight minimal deviation towards the right. That's all normal. And you can look for air in this region, subcutaneous emphysema, sometimes in those with chronic cough or following a trauma or even certain surgeries, you may have air in the subcutaneous plane. Subcutaneous emphysema can be missed easily unless you look specifically for that. And in rare cases, there could be mediastinal emphysema or pneumomediastinum, which have to be looked for specifically. Otherwise, you're going to miss it. Then in the ribs, you look for rib erosions on the lower borders of 3 to 8 ribs on both sides. Those are the things which you are likely to miss. Then cervical rib can be missed unless you look for it. Some cases, cervical rib can present with symptoms similar to cardiac pain because of the root pain. There are differentiating features, and you always look at the cardiophrenic angles and costophrenic angles. This is the cardiophrenic angle, this is the costophrenic angle. Small pleural effusion may be visible as just obliteration of the costophrenic angles. And in case of cardiac shadow, you look at the cardiac size approximately. It's a very simple method. Just measure it. You expect the aortic knuckle here, and this is the pulmonary bay. If there is pulmonary hypertension, dilatation of pulmonary artery, there will be a bulge here. This is known as the first mughal. If there is a bulge here, that is the second mughal. And if the left atrial appendage is prominent, then it will be third mughal. Normally, the cardiac apex is formed by the left ventricle. Here you can also see the descending aortic shadow. Probably it is from an older person with a slight dilatation of descending aorta as well. And this is the left cardiac border, this is the right cardiac border. The right cardiac border is usually flush with the skeletal line. Here slightly it is there to the right, it may not be significant. If it is significantly shifted to the right, then you will say there is right atrial enlargement. In vascularity, you can easily see main pulmonary artery if it is dilated. Right pulmonary artery is seen here. Left pulmonary artery usually goes behind the cardiac shadow, so it may not be visible. If it is grossly enlarged, then it could be visible. And this is the tracheal air column going down here as right bronchus. Right bronchus is more vertical, and you can see branches also here. This is the left bronchus going down here. It is more horizontal, and this is the carinal angle. You look for carinal angle widening in case of left atrial enlargement. And left atrial enlargement, in addition to having the left atrial appendage prominence, there could be a dual shadow here, shadow within shadow, double mitral, all those are the features. In vascularity, you compare the upper zones and lower zones. Normally, due to the effect of gravity, lower zones have more vessels compared to the upper zones. And for assessing situs, you have all these features: stomach air bubble and the shape of the bronchus. In dextrocardia, it will be reversed. That is, right bronchus and left bronchus will be reversed if there is situs inversus. And liver shadow also will be reversed in situs inversus. If there is no situs inversus and if there is dextrocardia, then it is called as isolated dextrocardia, which is more likely to be associated with cardiac malformations. This is majority of the heart shadow is on the left side. We call it as levocardia, and the apex should be pointing towards left. In dextrocardia, majority of the cardiac shadow will be on the right side, and apex will be pointing to the right. Usual chest x-rays are taken in full inspiration so that the lung fields are quite clear. If you take in expiration, lung fields clarity will be lesser. But there is a specific situation where you might take in full expiration. That's when you want to see a small pneumothorax. There could be a small pneumothorax which may be better visible when taken in full expiration, as the contrast between air and lung tissue increases. Coming to air, always remember to look for air under the diaphragm in pneumoperitoneum. Person coming with chest pain could be having perforated peptic ulcer also. In olden days, it used to be common, and you will see air under the diaphragm. Here it is not there. In cardiology, you also look for prosthetic valves, implants, and calcification of valves. If you take this line joining pulmonary bay to the right cardiophrenic angle, aortic valve will be situated above that, prosthetic valve or calcification. Mitral valve will be situated below that. There could be different types of processes. Then sometimes there can be coils implanted in the ductus like here, or there could be major aortopulmonary collateral arteries which have been coiled in congenital heart disease. Then you could have pacemakers or implanted devices. There could be devices in the pectoral region, pacemaker or defibrillator or cardiac resynchronization therapy. Then you will see the leads also. All these we will cover in later classes because there are images to be shown.